I am Dr. Chandrasekar, Senior Consultant Neurosurgeon at Apollo Cancer Center, Thenampet, Chennai. Today, I thought I'll give a small brief overview on spinal tumors and how do we manage them in the present day. Neck and back pain are amongst the commonest causes of disability that we come across in today's world. And almost 80 to 90% of us will encounter this at some point in our lifetime. This is possibly due to the erect posture we as human beings have attained from the four-leg posture. It's a major socioeconomic and health problem not only in India but across the world. It is the number one leading cause of disability in patients who are under 45 years of age and second commonest reason for them to visit an hospital. The commonest cause of neck and back pain is something called as musculoskeletal strain, or also known as fibromyalgia. A distant second is the disc prolapse or the herniated disc, which we keep on frequently hearing all across. This could be either in the neck or in the low back. These are the two common sites where we generally tend to come across disc prolapse, primarily because they are the most mobile areas of the spine. Further uncommon reasons for neck and back pain could be either trauma-related spine injuries, or it could be because of infections like tuberculosis, or congenital or developmental anomalies, something called as atlantoaxial dislocation, where the bones are unstable and they move one over the other. Something called as tethered cord syndrome, where the development abnormalities lead to the spinal cord getting tethered lower down, producing back pain. Then, of course, of interest for today is the spinal tumors. Spinal tumors are not very common occurrence. They account for less than 1 in 100,000 per year. Tumors of the spine can either arise from the bones or they can arise from within the contents of the spinal canal. These tumors are of two varieties. Either they could be benign or they could be malignant. By malignant, I mean cancerous tumors. These cancerous tumors could again be for two reasons. Either they could be a tumor spread from elsewhere in the body. Patients could have had probably something called as CA breast, carcinoma of the breast, or carcinoma of the prostate gland, anywhere else in the body which spreads to the spine. That's called as the metastatic lesion. The other one is a primary bone cancer, which could be either arising from the primary bone, spinal bones, something called as osteosarcoma, or they could be from within the substance like spinal cord. Common ones are the gliomas of the spinal cord, sometimes deposits within the spinal canal called the lymphomas. Pain is one of the commonest presentation in patients with any spinal disorder. So this pain either could be in the neck, they could be in the back, low back, mid back, and radiate from the neck down into the hands, either one hand or both hands, or they could radiate into the lower limbs also. Some of these patients can present to us with a band-like sensation when it involves the torso, the body. Eventually, it all depends on where the lesion is located. Apart from the pain, these patients can also come to us with weakness of the hands or legs, again depending on the location. This weakness can be varying. Some patients can present with early weakness, some patients can have gross weakness by the time they have come to us. Occasionally, some of these patients can also, just as a presentation, it could be instability while walking. They are not stable, they don't feel very stable, they feel very unconfident walking in the dark. Occasionally, they could also present to us with urine and motion disturbances. Once we have evaluated them clinically, we would have made a diagnosis as to where could the most likely site of involvement could be. So based on that, we evaluate these patients further with MRI and CT scan. These are the gold standards now to diagnose these lesions. Unlike earlier days, we had to go by X-ray findings. By the time the lesions used to be diagnosed with that, it could have been really totally unmanageable. Now with the MRI and CT scan being available, we are able to pick up these lesions at a much earlier stage. We are able to delineate them very clearly, and this gives us a real head start to manage these lesions. There is one other situation where we use something called as a PET scan, where like if you have a metastatic lesion, as I just mentioned earlier, the tumor that is spread from elsewhere, if you do a PET scan, you could also pick up lesions which might have spread to elsewhere in the body, extent of spread. Once we have this, then the next step is to go ahead and manage these patients. The primary treatment modality in these patients will be surgery, which will entail a small opening, and with this opening we usually try to get the tumors. Almost 2/3 of these tumors are benign, and consequently if you are able to get the whole tumor out, which is usually the norm, they generally tend to have a very good outcome. It is the remaining 1/3 of the patients which are malignant, again mentioned earlier, whether it could be a primary tumor or tumor that is spread from elsewhere. If it's a primary tumor, we are able to almost completely excise it, even if you are not able to totally excise it, and then subject them to further adjuvant treatment like chemotherapy or radiation. Depending on the pathology of the tumor, they tend to do well. It is the malignant tumors which are spread from elsewhere from the body, and also depending on the extent of involvement, that will dictate their eventual outcome. So once we have done this, once these patients are being managed surgically, which now have the results are dramatically improved, primarily because of the modern day surgical techniques assisted by the present day technology in the form of microscope, endoscope, image guidance, intraoperative monitoring. All this are dramatically changed the results compared to just even a few decades back. It is now to decide what further treatment the patient will be required. That will depend on the pathology. So once we have the pathology, we decide whether it will be a radiation oncologist or a medical oncologist to be involved, or either of them will be involved for further management of these lesions. Once that's been decided, then the next step would be to go ahead and have those lesions treated. Coming to the outcome, as I said, 2/3 of the patients are all benign lesions and they should really do very well. It is the 1/3 of the patients with malignant tumors which will be dictated by the pathology and the extent of involvement. In case of benign tumors, only once they are coming at a very late stage where they have been completely paralyzed for a long period of time with no bowel bladder sensation and no sensory feeling, they are the only small numbers who don't do well, but that is a very, very minuscule number. Overall, as compared to earlier, we have now come a long way, and I think definitely the earlier we pick up these lesions, the better for the patient, and they are going to do very well.